So, hi friends. Today we will study about the hepatic encephalopathy. So, hepatic encephalopathy, it's an complication of portal hypertension or cirrhosis with portal hypertension or advanced liver failure. Okay. Hepatic encephalopathy is characterized by there are some key points we should keep in mind. First of all, I must tell you that today's plan is we will which are the points or the things which we have to keep in mind, or we should more focus in hepatic encephalopathies are one thing that I will stress upon is key points which we have to keep in mind. Then other points are are grading system of hepatic encephalopathy. Then there are types of hepatic encephalopathy, about the precipitating factors, and again pathophysiology, not in much detail but little bit which we is necessary for our understanding. And after that, the criteria in grading only, that is West Haven criteria. West Haven criteria, very very important. And now the modified West Haven criteria or the Sonic criteria, we have to read this, or we have to know this criteria. Okay. And at last, the treatment of the hepatic encephalopathy. Okay. So these are the this is the plan for today's lecture. Okay. First, we will start with the key points. Key points in the hepatic encephalopathy is, first of all, it is an reversible condition. Okay. So hepatic encephalopathy is reversible, and it is preceded by the precipitating factors. There is always some precipitating factor is present there. Okay. So we have to identify the precipitating factor, and if we avoid or remove that precipitating factor, the condition is reversible. And hepatic encephalopathy is characterized by the neuropsychiatric feature. Okay. It is characterized by the neuropsychiatric features. And there are grading, there are types, and these key molecule or the key toxin which lead to the hepatic encephalopathy, that is ammonia. There are various other endotoxin also which can lead to this condition, but the key molecule is ammonia, So it will lead to the key cells which is affected in the brain, which lead to the hepatic encephalopathy, or the neuropsychiatric feature which leads to the intellectual function dysfunction. So the key cell affected in hepatic encephalopathy is our astrocyte. Astrocytosis occurs, astrocyte edema occur, brain edema occur due to the ammonia, or I will tell later what happens in astrocyte. Okay. So these are the 5 key points we have to keep in mind. That is, hepatic encephalopathy is reversible. The cause is usually the various precipitating factors having characteristic neuropsychiatric features, and ammonia is the key toxin along with other toxins, and key cell affected is astrocyte. Now, how ammonia lead to the hepatic encephalopathy is that in the gut, in our gut, ammonia is produced, and in cirrhosis patient with portal hypertension, ammonia production is increased. How ammonia production is increased? Because of there are mainly the three reasons: due to the bacterial translocation or bacterial overproduction, ammonia producing bacteria are increasing. And again, there is dietary proteins are degraded, which again release this ammonia. And in enterocyte, in our intestinal cell enterocytes, there are various enzyme, that is glutaminase enzyme is there, which will convert glutamine into glutamate plus ammonia. So again ammonia production is increased, right? So ammonia is increased in the cell, and this ammonia is usually detoxified. Where it will be detoxified? As we all know, it will goes to liver. But as the patient is having advanced liver failure, no detoxification. So it will, shunting will occur, portosystemic shunting will occur. It will go to systemic circulation and will go to brain, pass the blood-brain barrier, and main target is asterocyte. In the asterocyte, what will happen? In asterocyte, this ammonia will combine with glutamate and will again produce glutamine. Okay, so this glutamine is the highly osmotic substance and will lead to the astrocytosis or astrocyte edema. Astrocyte edema will occur, and this glutamate is also a excitotoxic agent, or it will also lead to the neurotoxicity, and neurotoxicity will occur, astrocyte edema will occur. There are again other region also, that reactive oxygen species also increase, reactive nitrogen also increase. Okay, so this is the so patient will have the various neuropsychiatric manifestations, which I will tell you further. So this is the main reason of the encephalopathic feature of the patient, and how the ammonia will lead to the, there is various more complicated mechanism of neurotoxicity. We don't need that much, but just keep in mind that in brain, astrocytes are the main cell which are affected by the, which are damaged by the increased ammonia level in the blood, or hyperammonemia, right? Okay, let's now go to the precipitating factors. Precipitating factors, which are very, very important, because whenever we suspect in a patient of advanced liver failure, when we suspect the patient may have the hepatic encephalopathy, we always look for these factors and we have to try to avoid these. Okay, in the treatment of the in the managing the patient of the hepatic encephalopathy, this is the first step to identify the precipitating factors. So first we should know the what are the precipitating factors. First and foremost is the increased nitrogen load. Nitrogen load is increased. So what are the conditions which can increase the nitrogen load? Is one is a constipation, and there is the GI bleed, also leads to the increase in the nitrogen load, and dietary proteins, and again azotemia. Okay, these are the conditions which can lead to the increase in nitrogen load and can precipitate to hepatic encephalopathies. Other condition is infection. Bacterial infections also leads to the increase in the risk of hepatic encephalopathy. And one thing is that this ammonia combine with H plus and form the ammonium. Okay, this is non-toxic, this is the toxic product. So whenever there is a acidosis in the gut, reaction will shift to the right, and less toxic compound will be there. Like less toxic compound will be there. So if there is alkalosis, in the alkalosis there will be shift in the left and more ammonia will be produced, and hepatic encephalopathy will be precipitated. So alkalosis and the condition which cause the alkalosis, like the hypovolemia, hypovolemia, hyponatremia, and this our vomiting, because vomiting and hyponatremia, hypovolemia will occur, RAS system will activate, and again this will lead to the alkalosis. So all these conditions, hypovolemia, hyponatremia, vomiting, alkalosis, will leads to the more of the ammonia production. And again the various CNS drugs. CNS drugs is mainly the sedative ones. Okay, sedative ones. So we should try to avoid the sedative medications in the patient of hepatic encephalopathy, because they itself precipitate the hepatic encephalopathy. So precipitating factors, very very important. We should keep in mind all the factors which will increase the nitrogen load, that is constipation, GI bleed, dietary proteins, azotemia, all these. At the again others are the infections and these very conditions, hypokalemia also, and these sedative drugs. So let's go to the types of hepatic encephalopathy. Types of hepatic encephalopathy, there are 3 types, very easy, that is A, B and C. So A for acute liver failure. So hepatic encephalopathy in acute liver failure condition, right? And C for cirrhosis, cirrhosis with portal hypertension, cirrhosis plus portal hypertension. So hepatic encephalopathy in the patient of cirrhosis with portal hypertension or the advanced liver failure or chronic liver failure. B in mainly the other than the patient will not have any intrinsic liver disease like extrahepatic like in the tips, we can say, in the shunt procedures and all. So A is the because it occurs in the acute liver failure conditions now, so it will, A type is more severe, more of the brain edema will be occur and it is a more severe, and C is the most common which we usually see the cases of hepatic encephalopathy are type C. Okay, then the most important is the grading of the hepatic encephalopathy, that is West Haven criteria. West Haven criteria, or now the modified one are we used, modified one, modified, or also called the Sonic criteria, not called but Sonic criteria also there, in which we will study. Okay, so there are 4 grades. One is 0, one is minimal hepatic encephalopathy, then 1, 2, 3 and 4. So 4 grade is there. So this grade 0 is patient is normal, right? Grade 0 is patient is normal, and minimal hepatic encephalopathy and grade 1 is called as covert hepatic encephalopathy or HE, and grade 2, 3, 4 come under overt hepatic encephalopathy. So now we will see what is a minimal hepatic encephalopathy is grade 1, 2, 3. These are very very important. Let's see. So grade 0 is normal patient. Minimal hepatic encephalopathy patient usually seems to be normal, but there is only one feature, that is decreased attention span is there. Okay, and when we will do the neuropsychometric test, so when we will do the neuropsychometric test, they will be abnormal, right? So like the Stroop test is there, number connection test is there. So patient will have only abnormality on the neuropsychological examination, and patient will have the decreased attention span, right? Now the grade 1. What are the feature of grade 1? Grade 1 patient will have the key feature is altered sleep behaviors, altered sleep pattern, we can say. And there will be some, we can say there will be some personality and behavior changes also, but main is the altered sleep pattern. Okay, and this is about the our cohort. Now we will see the grade 2. Grade 2 patient will have Asterixis, right? Will have the Asterixis, and the patient will be disoriented. Patient will be confused. So all these features is present in the grade 2. Now grade 3 and 4 is like we have to remember, we should aware of two term only. Grade 3 is patient is in the stupor, but the patient can be awakened by the deep pain. Okay, so grade 4 is patient is in the coma. Patient will be the coma, and this will we no need to know that much. Patient will be in the coma. So grade 0 patient will be the normal. Minimal hepatic encephalopathy, there will be the decreased attention span. In grade 1, altered sleep pattern and the behavior and personality problem. Grade 2 will be the Asterixis main, and other patient will be disoriented and confused. Grade 3 is the stupor, and grade 4 is the coma. And we should also, one thing we should keep in mind, that in covert their EEG will be normal, and in overt EEG may show some abnormalities, right? So just keep in mind this. So just only one point, like where Asterixis will be more prominent in the grade 2, where will the patient will be disoriented in the grade 2, altered sleep pattern occur in the grade 1, in the stupor occur in the grade 3, attention span will be decreased in minimal hepatic encephalopathy. These are all the points we should keep in mind, and what is the covert and what is overt. Let's finish this. Now the last we come to the, that is the I think almost we have done. So let's just come to the treatment part or treatment portion. Okay, so treatment is, first is identify the precipitating factor, that is the treatment of the precipitating event or the precipitating factor. And second is our lactulose or lactitol is the main treatment in the hepatic encephalopathy. So how lactulose is working there? Lactulose bowel wash is given. How lactulose is working there? Because lactulose is a non-absorbable sugar, so it will be degraded by the colonic bacteria and will leads to a creating, there is a acidic pH. Okay, as I already told you, acidic pH will shift to the reaction to the right, and more of the ammonia will be converted to the ammonium, and toxicity will automatically decrease. Okay, so lactulose bowel enema is given. Again, rifaximin is given, either the 400 milligram in TDS or the 500 milligram BD dose. And again acarbose can be given. Acarbose, that branch chain fatty acid like LOLA, L-ornithine, L-aspartate can be given. And the sodium benzoate, although sodium benzoate is not much of use, we use the lactulose, treat the precipitating factor, and just use the lactulose and the rifaximin. in some conditions, this Lola. So this is about the treatment. So I teach hepatic encephalopathy just for some of the practical points and some of the MCQ points. I think I'm able to convey to you. Thank you.